Welcome to this recording of MOAR's June 1st Boston Action for Recovery meeting, focused on COVID-19, the experience, the evolution, and the economy. This meeting is facilitated by MOAR's Regional Coordinator for Boston and the Northeast, Julie Bunch. Here she is.
As we always do, we want to start with the MOAR mission to organize recovery individuals, families, and friends into a collective voice to educate the public about the value of recovery from alcohol and other addictions. And we want to welcome everybody to the Boston MOAR meeting. And we just want to start with, we need to begin, and we just want to please recognize with the brutal slaying of George Floyd. This was an act of violence that moves to anger to support the action for justice, to erase the violence and disparity. So if we could just kind of give a moment of silence for that. Thank you. COVID-19 and disparity. COVID-19 hit a vulnerable population experiencing the disparity of addiction, homelessness, many with communities of color and their caregivers. The needed protective garments, testing, safety measures for treatment, recovery services came to the forefront. Moves for telehealth, outreach, segregated services, homeless, hotels, medication, take home, food, shelter, water, and sanitation. Thank you to Governor Baker, Secretary Mary Lou Sutters, and the Mass Department of Public Health, BSAS, with Mayor's Office of Recovery Services, treatment providers, healthcare, and all the frontline workers for listening and responding. We applaud the peer recovery support centers, recovery coaches for moving online so spontaneously. We will learn from our guest speakers about the actual experience, evolution, and the economy. We will focus on the lessons learned and action for policymakers, education agenda. What we thought we would be advanced advocating for has been adjusted as the economy has been hit by a $5 to $7 billion deficit. We will be making the case for the value of addiction prevention, treatment, and recovery services. Let's keep addressing disparity at the forefront. MOAR is grateful to be on the Legislative Behavioral Health Committee chaired by Rep. Marjorie Deckers. Issues are being addressed. Your voice is more wanted. Just to go over some of the things that on May 4th meeting, we had Massachusetts Recovery High School, and they talked about COVID-19. Speaking of recovery services, how about the first 5 recovery high schools in Massachusetts? We heard from Roger Osher from William J. from the Recovery High School. We learned that the schools provide high school education, individualized recovery support for the students. The schools adapted to online learning when COVID hit. They stay at home and they're doing very well. The students are in contact with teachers and administrators daily. Auden, a senior, shared living proof that she has been given the support needed to focus on her studies and artwork. Without the school, Auden would not have this support. If you want to help the high school student who has been struggling with addiction and just might benefit from high school environment, then there is a website that you can go to that I have that is on this flyer. Also, they welcome anybody who would like to go in and speak with the students, and you can get that information from me. So with that, we can go on, and our first speaker, Marianne, who's?
The first speaker, John McGann from the Gavin Foundation with Jen Callahan from the Divine Peer Recovery Support Center. Hey, John.
So thank you, Marianne, for inviting us to be part of the meeting this evening. And I guess I can speak a little bit about what we've been doing at Gavin and what the Recovery Homes Collaborative is, approach has been to dealing with COVID-19. For many, for Gavin, our own programs, what we've really been trying to do is we've been full capacity at the detox and stabilization unit, taking people in as they need help. We know that now more than ever, we want to get people off the street and get them into treatment and get them medical care. So we've been taking people right in. And what we've been doing for our residential programs is really trying to take from as much as we can from our own CSS program and get people into treatment that way. That has been one of the ways that we've been able to keep staff and residents of the houses' fears down about who's coming into the house and how much medical care they've had before they walked in. So that's helped us to be able to keep the programs stable. So that's what we've been doing on the residential side. And what each Gavin has done, and a lot of members of the Recovery Homes Collaborative, is in our residential programs, we've had to cut capacity just a small amount in order to make sure that we had space available to do isolation rooms should somebody show signs of COVID, that we can instantly isolate them and put them in a room while we waited to get a test and to see what kind of medical attention they need. So I know a lot of the recovery homes fall along that same model. As far as our outpatient program, we've obviously gone to telehealth and virtual. It's a way to try to keep people engaged. One of the things that concerns us is that we do a lot with criminal justice population, and they've been hard to really track down without any kind of leverage. Newer people that we hadn't had an opportunity to thoroughly engage with. So we're a little concerned about that. And one of the other concerns we have, and I know that Emily is on here and would be interested to see what kind of impact this might have had on her. But one of the things that we've experienced is when people are getting the checks, their unemployment checks and back checks, they're running out of treatment unless they've really engaged and been in treatment for a period of time. And that scares the heck out of us because they've been through detox, they've been stable for a little bit. Now all of a sudden they got all this money and we're worried about them, people going out, and we know it puts them at a higher risk for overdose. So we're very concerned for their safety from that perspective. So I think that any chance we get to work with individuals and family members to make sure that they have a safety plan for people in early recovery that are getting these rather large checks, I think is a good thing to do. And if we don't, I think it's a missed opportunity. The other thing that Gavin was part of and that we were happy to be part of was we worked with RISE and others early on in this to get some funds for people that were in certified sober homes, so they didn't get discharged because they didn't have rent money because of the quick layoffs and confusion around policies and procedures coming out. So we were able to, in the beginning weeks, keep people in their certified house through various funding sources. And like I said, with the help of RISE and others, and what we were able to do is really set the stage for the Department of Public Health, the Department of Probation, and the Parole Department have all now ponied up funds to make sure that people coming out of incarceration or involved with probation, or people that are coming out of DPH programs have access to funds, that the houses, certified houses, have access to funds to be able to make sure that they stay housed. We don't want people to lose their housing as we go through this. So we're very pleased with the work that we were able to do with that and really set a tone for others in the state to jump in. So we've been busy trying to do our thing. So that's where we're at. And I know Jen will cover the recovery center piece. So I'll jump off at that point. Thank you.
Thank you, John. And thank you for really setting the stage so that people could get their sober housing. That was so important while people were losing their jobs. Very, very important. And thank you for all you do. So Jen Callahan.
Hi, everybody. Jen Callahan. I'm the program director over at the Divine Recovery Center for Gavin. So far through this whole COVID-19 thing, we've done our best to keep our members engaged through Zoom and telephones and stuff like that. And you know, it's worked, but we all know that there's a vulnerable population that doesn't have access to those things like phones. And even if they have phones, like where are they going to charge them? And you know, that's been a huge hurdle. So like with the things coming out with the governor and the governor starting to open things up and hopefully Marty opening things up soon. Sorry, my phone keeps ringing. With Marty opening everything up soon, like we've put in some areas that like we're gonna utilize outside space in our building to try to adhere to the social distancing, and you know, we're gonna try to set up charging stations outside the building so that people can get their phones charged so that they can go to these Zoom meetings. You know, we can direct them towards the park across the street, and you know, we'll be able to help those people that are looking for detoxes and set up safety protocols so that you can have one person in the building with one staff member so that they can make phone calls if they can't make it, if they don't have phones, and you know, be able to give them the resources to like where can they get tested, things like where can they go to get food. You know, there's meal programs available all over South Boston that, you know, we have access to, whether it be the food pantries or day programs that are just giving out lunches and dinners. You know, there's a lot of things going on that the homeless population in our area, which is a big part of our membership, is missing out on because they don't have the access that a lot of our other members have. So things like that are on the horizon, and you know, we're looking forward to turning the corner with this COVID thing. I know it's not going away, but you know, we've put the procedures in place so that we can start to open up a little bit, be more available for the population that's been kind of left to the side a little bit because we didn't know how to help them. So thanks.
Thank you, Jen. That's very uplifting. You're going to have a little like cafe on the outside of all kinds of supports for people. And so good to hear about the outreach to the homeless and putting the charging stations right there.
Can I just ask a question, Jen? Do you know like what your hours will be, or?
So as of right now, we don't know any of those things. All of those things are going into place now. You know, John and I have sat down and we're sitting down with BSAS, and there's a lot of questions that have to be answered, but we're all gonna make the right decisions to make sure everybody's safe.
Okay.
Excellent. Excellent. Wow. This is more exciting. Can we, we're going to move on now to North Suffolk Mental Health with Katie O'Leary and Loretta Leverett. So like, take it away.
Yeah, so we do. We have a peer recovery support center opening in East Boston. I'm not exactly sure when, hopefully by Labor Day. That's really about all that I know.
That's good. That's a good recovery month thing to happen.
Yeah.
Very good. Excellent. Thank you.
And Miss Loretta probably has more news.
Yes. Loretta Leverett.
Hi, I'm having trouble with my Zoom. Is it just me, or is everybody else freezing periodically? Because my screen keeps freezing. But at any rate, must just be me because no one else is saying that they're having trouble.
Bringing warmth to this whole meeting. So thank you.
So I really don't have a lot to report in view of the fact that our site, once the moratorium on construction was lifted, actually I'm going over there tomorrow, but the new site in Roxbury, I would believe would be ready at the end of the month.
Wow.
And I'm hoping, and that we'll be able to get everything moved in there the beginning of July. So all the, you know, in the meantime, where we are located in Mattapan, the site that, because it was designed to be a temporary site, we are not going to be able to allow anybody to come in other than the staff, because the site is very small. But we are still going to be able to, we're hoping to do some things outside of the center there in Mattapan. The weather is turning warm. We will come out, we will give masks to, to any of our community that wants to come to the center. If people need.
Lorraine, can you say anything or, yeah, unmute yourself.
Okay.
Okay.
So as Loretta was saying, we're hoping to set up some tables with social distancing in place and hopefully make some packets of information of services and resources in the community. Complete packet would have, gloves and masks and hopefully, if we can, sanitizer. We are looking forward to the new place, but in the interim, we will continue doing what we are doing, which is providing services like a book club. We're moving forward, which is our group. We do all pathways to recovery. We do a check-in and it's called a how you doing. First thing in the morning, how are you doing? And then in the evening, it's how you doing now. So in our calendar, our calendar is up on the on our website. I facilitate a NAMI group. What else? Caitlin, help me. I do some. Let me see. There's a NAMI group. There's a women's group. There's a pathways group. There's a book club. There's what did I just say? The check-in. And I'm sure I'm missing something, but all that we do is.
Sounds like you're online all the time.
Yeah, I feel like I'm on the time all the time, but it's good. We in the best that we can. We are rising to this occasion and reaching out to the community and trying to stay engaged and trying to even bring new people in. So we're on it. I'm still giving recovery coach services. My clients are checking in. We are having sessions on the phone. So, the work continues, and as struggle does, the work continues.
Yeah. Lorraine,
we're looking forward to moving forward in a new place.
Lorraine and Caitlin and Miss Loretta, thank you, because I've been down there and you guys still been, soldiering on, and I'm very excited for you guys to be moving into your new place. So
yes.
And also on our Facebook page, there is a link to download an app. We have an app now for your phone that has our meetings also.
And it's real simple. And Caitlin designed it. Caitlin did
that.
Caitlin did that. Kudos to Caitlin. All right, I have a group that I have to go to. So I'm going to see me disappear. I'm leaving. I'm going to probably leave in about 4 minutes. But thank you guys, and thank you all for all your continued work. And we need to everybody take our hand and pat our back because we have risen to this occasion. I'm so proud of us. I really am.
We're proud of you. Very good. Step rock. Excellent.
I'm back.
Oh wow. Lorraine just talked about how you're online all the time.
Yeah. I think most of the centers are online and trying to provide the services that people can come into the center to attend as they did in the past. But I don't know if they've already spoken about that we plan to go over to 153 because the outside of our building is all done. They're just doing the internal stuff that we're going to try to social.
Yep. That's that social distancing outreach we were talking about that she just froze on. So yeah, I have to go.
Okay.
Thank you, Lorraine.
You're so welcome.
Yeah. Thank you, Loretta.
So, bye, Katie. It was good seeing you.
Yeah. Very good. All right. Why don't we move on to Matt Donlin with the Addiction Treatment Center of New England?
Hey, Marianne. Thanks, guys. Thanks for inviting us to, so my outreach coordinator, Amy Livermore, is also on the call.
Fabulous.
So, we've had a unique experience with COVID-19, as I'm sure many of us have, and we had to kind of learn quickly about how we were going to facilitate everyone, obviously as an OTP, everyone getting their medication and receiving clinical services. We almost immediately discontinued groups. I think very early on in March, we had no choice but to discontinue groups. And, then the state has been great as far as guidance, and our OTP group with the ABH has been amazing in providing just guidance and what the next step looks like, because there's no blueprint for this. And so we kind of had to trial by fire and learn quickly about how we were going to write policies and put protocols in place to make sure that we were able to get everyone medicated safely, practicing social distancing and using all the PPE and everything that comes along with the COVID-19 prevention. So, we were able to get guidance from SAMHSA and the state about take-home medications and how the regulations became more lax to be able to provide the 28 and 14 take-homes for more stable patients, which was great because in January we had gotten a grant from SAMHSA to expand services. So that brought on Amy, the outreach coordinator, and a recovery coach, but it also allowed me to expand my dosing hours. And, unbeknownst to us in January and February, when we were planning all this out, the expanded dosing hours would really come in handy when you need to stagger the dosing for so many different people and figure out a system where not everyone's coming back on the same day and there's no lines and people are able to safely distance. So, it took us about a week to be able to figure that out, but we were able to do it and get people on a set schedule where they were coming back, at certain days and certain times. So there were no more than 3 people in the dosing building at the same time, all practicing social distancing. And in the meanwhile, writing policies to coordinate all this stuff. As far as the groups, I know some people have had success with Zoom groups. We haven't. I think a lot of it has to do with the population we serve. Jen kind of spoke to it a bit. So we have, given people a lot of resources about self-help online Zoom groups, but we have been primarily focusing on individual sessions through telephone, which has been very helpful. It's so we've increased that to, a couple phone calls with clinicians for each patient every week. And we've been able to maintain safety. We've only, so we've had 2 people, I think, that tested positive out of our whole population, I think 270 people or so, and both were in hospitals when we got the news that they had tested positive. So, anyone who was presumptive positive or showing symptoms obviously got dosed outside the clinic. And was able to get take-home medication so they could self-quarantine. And we just really, knock on wood, no staff has tested positive, no presumptive positives. My medical team and nursing staff has been really on top of screening and making sure that, everything. I have a new director of operations who's great, and she's been really on board with cleaning, making sure everything is sanitary. And we probably have a dozen people that we have determined that it's probably not the best bet to give them take-home medication. And that's just what it is. It's the medical director's call. If they're not safe to be able to handle take-home medication, they still come for daily dosing. But again, very staggered in time, in making sure that, there's never a line. Let's put it that way. So we're really, it's all, like I said, no blueprint. We're all kind of learning as we go, but I think we've been very cautious and also very lucky. I don't like to think that we have all of our ducks in a row every single day, but we've been lucky that, we've been able to make sure everyone gets help, gets the treatment they need, gets the medication they need. And, we're still working in the background. It's given us some time. So we just got approved to treat Medicare clients, which is huge. And I know that a lot of OTPs have been working on that, and we're, getting contracts with Cigna and another payer. Off the top of my head, I can't remember it, but we've, really worked hard in the background. We're actually painting the inside of the facility when there's not, because there's not a lot of traffic there. So we're taking this time to, to expand and also to, pretty up the place. And so far, so good. Everyone's been in a really positive spirit. All my clinicians are working from home. And there's usually one clinical person on site every day to handle crisis situations and things of that nature, along with a recovery coach, sometimes 2 recovery coaches there every day. So we're still doing intakes 5 days a week. We basically have 7.5 hours of dosing Monday through Friday and 5.5 hours on the weekend, which is pretty lengthy to be able to give people the time they need to get to the clinic to get their meds and see a recovery coach or talk to a clinician. We've been seeing, some influx in, single ridership from PT1 and, transportation issues with the MBTA running on a Saturday schedule, just all the little hurdles that we've been able to overcome. And the expanded hours has been really great.
Wow. It sounds like you've been really, like for No Blueprint, you created one in a very positive way. If the social distancing and the COVID-19 were to end, is there anything that you would want to keep from this experience?
So I think, ironically enough, I was talking about today with a couple people over coffee, and so we have patients that would not typically meet all of the criteria for take-home medication. And these people are doing really well with it. And, I was talking to you earlier too, I'm pleasantly surprised with the ability for people to step up and engage in their own recovery and be able to handle the responsibility of, 13, 14, 15 take-homes at a time.
Amazing. Wow.
So we have a question in the chat box from Paul. Is this from you, Paul?
Yeah.
Do you want to ask it or do you want me to read it?
No, I think you kind of answered it. I asked what percentage of the people did you think are getting take homes, and you said only 12 weren't. So that pretty much, I think, answered that question. And how is it going on the closing of holidays? Have you guys been able to do that, or has that been a struggle to do that?
So we actually did close on Memorial Day, and everyone was able to get take homes that one day. And it was approved by the medical director, and the exemption was approved from SAMHSA and BSAS. Realistically, I think a lot of other OTPs have other sites, so they're able to close one down and dose people somewhere else. I don't have that luxury. So if there's one person that is absolutely unstable, I have to stay open. And you know what? That's fine. That's fine. You know what I mean? It's one nurse there for 5 hours. We err on the side of caution. I don't want to, put anyone in jeopardy. So, but we have been able to close for a couple holidays this year. And July 4th, I don't know if I'm going to do it because it falls on a Friday, Saturday. So I'll probably hold off on that. What street are they moving to? Is that what you said? Is that for us?
That was the Step Rocks. I'm sorry.
Oh, okay. I was like, I haven't heard that we're moving, but.
Is there anybody, I didn't catch is there anybody from Step Rock still on here, or did they all leave?
I'm here, Caitlin.
Oh, okay.
So we're moving to 5, what is it? Miss Loretta, help me for a minute. I think it's 530 something, but it's on Blue Hill Ave in Roxbury. So we're still going to be on Blue Hill Ave. It's across from Merengues, if anyone knows what that is. Okay.
It's at 153 Blue Hill Avenue.
Thank you.
Excellent.
And you're right, Caitlin, it's right across the street from Merengue Restaurant. And we are very happy to see that public transportation stops right at our door, right in front. And we have a large parking lot right across the street that's free, and that anybody that comes to our center is accessible to them. So we hope to have some of the things before we officially open. We hope to do some things from over there.
Wow. And Sunshine Body says not too far from your old place.
Well, you
Well.
can't walk. You can't walk from the old place, but it isn't that far away. You're absolutely right, Scotty. It's not that far, and we are looking forward to the move. We've been where we've been since October, and it's been a long time.
Wow.
And Noel says there's parking there too. So
Right.
Yes, it's parking, but you know what? It's like starting a whole new center. You know, it's not, you know, moving from where we were to where we are now, even though it is not that far, but it's starting all over.
okay. Okay.
But that's not a bad thing.
Right.
Yeah.
Very good. We'll help you.
Anybody who came in a little late, can you just please sign your name in the chat with your email? And Mary Ann, who would you like
Who's next? How about Conleen LaBelle from the Boston Medical Center, OBOT, and she can say what OBOT is.
Good evening, everyone. Hi, Conleen LaBelle, State OBAT, which is office-based addiction treatment. So essentially being that we treat patients who have, well, mainly opiate use disorder only, because those are the only two real evidence-based medications we have that you can treat in an office-based practice. So buprenorphine / better known as Suboxone, and injectable naltrexone, better known as Vivitrol. And we treat patients with alcohol and benzo and cocaine, but we don't have approved medications. And we don't have great treatments. So essentially we're a nurse care manager model that's started at BMC back in 2013, has expanded to greater than 40 health centers across the state, and treated more than 20,000 patients in their communities, using nurses to basically help facilitate expanding treatment. So through COVID, all those models moved to remote access. Our programs are mainly all funded by the Bureau of Substance Addiction Services. So they fund the nurse care manager model to help expand treatment to work along with providers, because providers would typically be willing or able to take on caring for patients that were complex in their practice without additional support. So that's why it's been so successful. So BMC treats greater than 850 patients in this practice, and we moved them all remote, except those that are now getting injectable medications. So two of our medicines, one being the Vivitrol, known as injectable naltrexone, is injectable once a month. And then buprenorphine, the Suboxone, is now called Sublocade, and that's an injectable form that some patients take that's now once every 28 days. So we actually have a substantial amount of patients that are taking the longer acting injectable forms. So that seems to be progressing. And one of the wins with COVID-19, we'll take all the wins we can get from this horror, is that the Medicaid pharmacy program took the Sublocade off prior auth. So they allowed anyone to have access to that. So some folks chose to go on to the Sublocade, not just at our site, but at health centers and other places, because they didn't want to be worrying about getting their prescriptions. Because getting patients prescriptions is the biggest anxiety I think our patients are faced with, more so than their disease, because they have so many bumps in the pharmacy system, prior auths, co-pays, all those things. So anyway, so we've had clinic twice a week with the injectable piece, but we've had nurses managing the patients remotely 5 days a week. And with that, I mean, we've had great success. It's been amazing. People used to say, like, you have to come in, you have to give you urine to get your medication. So we took the urine away. We stopped doing urine screens, and we gave patients longer prescriptions, but yet they get on the phone with the nurses once a week, even though their prescriptions may be monthly. So what is the real carrot in that, right? So I think that just that relationship and and people right now are in desperate need of someone to talk to them and support them and help them through these really rocky times. So I think it's been incredibly successful in doing that, not always successful, but also patients have been texting. So we got work phones for all the nurses, and patients people love to text, right? It's just how we all communicate now. And so people would just send texts, and we're getting texts about lots of mental health issues, lots of people needing to get into treatment, inpatient, and what have you. So really able to meet those demands, immediately, as opposed to trying to get through to somebody on a phone or trying to get into an appointment. So there's been some of the wins that we've had with that. And patients feeling really supported in this rocky time and really nervous about their treatment and nervous about their medicine. And the state expanding the ability for us to get people longer scripts, allowing patients to pick up their prescription, allegedly, not always works, allowing them to pick up their medicine early, taking prior auths off, really taking the bumps away. They're not supposed to need an ID when they go to the pharmacy, not supposed to, but they often are still asked for it. So now that's been taken away. So a lot of things have gotten easier. And then we've worked with corrections. As we know, there's been a huge push to try to get folks out early. So with that, we worked with PARI and the houses and DOCs to try to just let them know that they could call us. Like, so somebody needed medication treatment, they could give us a shout, get on the phone with somebody in real time, get screened, get assessed, talk to a prescriber, and literally get started on their medicine or get that bridge script that they may need. And so what we're doing is just holding on to folks, and then if we knew they belonged in Holyoke and they wanted to get seen there, we'll link them over there as soon as we can get them to see someone, or we'll hold on to them until all this craziness dies down. And so that's been, so I think there's like 50 plus that we've seen at BMC, but a lot of the health centers are getting folks directly as well. They're not coming directly. They're not all coming directly to us, but many are. Also, some programs have closed down during this, and so we've picked those folks up. There's also folks that were at programs that were making them come in, and patients weren't feeling comfortable going in. Patients were nervous. We had this one guy from Western Mass whose wife had 2 craniotomies. He's like, I'm not going in there because I don't want to bring something home to my wife. And they were telling him he had to come in for a urine. So we're managing him until, said time he wants to potentially go back to his prescriber. And others making people come in just because that's what they were making them do. And some of that's related to revenue streams and the lovely urine that makes my skin crawl. I mean, so I think it's making us all stop and rethink this whole urine thing. It's kind of like Matt was talking about, like, patients doing well. I mean, we're still seeing people doing well even without that urine. Maybe it's not perfect, but they're in care, they're taking their meds, they're talking to the nurses, they're going to groups, they're going to drop-ins, and they seem to be hanging on. We've had a lot of problems with the patients in places losing their employment, recovery centers, which I think was talked about, but some of them are not in certified homes, so that clearly creates a barrier because the certified homes don't have access to that reimbursement for folks if they lost their job and they can't pay their rent. So that's one bump that we've seen. There's also the HEAL grant. You wanted me to talk about that, Marianne?
Yeah, please. Yes.
So the HEAL grant is in 8 communities. I didn't pick them. I have nothing to do with it. I'm just telling you what the story is. So there's 8 communities across the state. Holyoke, Lawrence, no, not Lawrence, the second one, sorry. Holyoke, Lowell, Gloucester, Salem, Brockton, Plymouth, Bourne, Sandwich, Shirley, Townsend. And so essentially they're putting a bucket of services into those areas to try to decrease overdose deaths by 40% in 3 years. And with that comes a lot of services and a lot of people working with the community coalitions, building additional coalitions and getting other people to the table and trying to literally bring everyone together. Because we all do great stuff, but we do it in our silos. And so how do you bring medical and street outreach and harm reduction and counseling and inpatient and outpatient and residential all together? And where are the holes and how do you find the holes? And so that's what it's supposed to do. Clearly, COVID has put a wrinkle in that and made things a lot more challenging. But that's what they're up to right now, and they're trying to do that. And in some of those communities, they're struggling to get the medical people to the table right now. And there's over $800,000 a year going into the communities. So getting the people to the table to tell and show where the holes are is hugely important, so that
Yes.
that money can go into the community. And so, but in the middle of COVID, the medical people are trying to save lives and or test people, or, you know, get people, you know, socially isolated, socially distanced. And so it's been a bit of a struggle.
Wow.
Um,
Yeah.
uh,
It's what you're sharing is tremendously amazing from the treatment during this challenging time of connecting people, using phone, using text, seeing people respond. Very, very positive. If you were to advocate, would you advocate for continued telehealth?
I would, I think, but we have to build it so that it works for everyone. It doesn't
Yep.
work for people who don't have phones. It doesn't
Got
work for people who don't have internet or Wi-Fi or a house sometimes. I mean, they
Yep.
can't talk somewhere privately. They don't have earbuds. They don't have somewhere to plug in their phone. I mean, those are the bumps. And so actually, I can't see it. Behind me, there's a whole ton of boxes. And so we got, initially Boston Medical Center got a lot of donations, which was very fortunate. And so we've been putting the money back to the patients. And so they got 500 track phones with 90 days of service on them. And so we've been handing them out to patients and people that end up over in the recovery units that had COVID. And then the state went ahead and they put additional money into that. And so now they've given money out to the community health centers to purchase phones and the OBATs, because they can't talk to the nurses and to the medical staff if they don't have the phone.
Got
But
it.
those things are short-lived and they're Band-Aid fixes if we don't have a way to sustain that. And then in Western Mass, there's no damn reception out there. I
Right.
saw something though last week, some federal grant about trying to expand Wi-Fi access to rural communities, and I thought that was super exciting, because
Yeah.
that's, you know, that's a huge barrier out there. So even when they do have a phone, they're not hearing the phone and they don't get the signal. And so those are barriers. And I mean, I think it's good, but it also is very isolating for folks. And you can't see people, and some people, we're trying to start with videos, but it's not safe and it's not always good. And if somebody's answering, you got to know, like, take the cues when somebody's answering you and how they're answering you, if they really are okay and if they really are safe. And, you know, so
Yeah.
but it's not perfect. But I think it's great for folks that are doing well. For folks that are at work and we're dragging in here and running through the neighborhood and potentially putting them at risk because there's people that may not be doing so well in the area, and then you're taking them away from their jobs. And I mean, so I think it's definitely going to help us think how we take care of people. And you don't need to run in all the time, but
Right.
you just figure out how do you sustain that.
Yeah.
I think it's definitely helpful, but not perfect.
Exactly. Exactly. I know Congressman Clark is trying to get a move to improve, you know, telecommunication with better service. I just read that too. So, and it's something we have been hearing from Western, you know, from the Western Mass, especially like in Franklin County, Pittsfield, that area.
Yeah, and we started 2 recovery coach drop-in sessions, which have been very, very popular. So trying to support folks out there that are on the front line that are doing this work, and that the work hasn't stopped. It's probably gotten more intense. And so those have been working out really well. And we also then have a formalized one that's been happening monthly. And then we started a patient group and patients with our recovery coach facilitating, and that's been really popular too. But I think, you know, like, it takes a while to get people to like the technology and comfortable and going and, you know, reminding them about it. But
yeah, up with coaching and power for communication, connection. Then Julie.
Oh, okay. So Christy asked for the list, and thank you, Matthew, for putting the link in the chat. So Christy, if you don't see that, there is actually, he put a lot of information about the human
healing community stuff.
Yeah. And I don't know why I don't know that, because I sit on.
Yeah. And we're also doing lots of training for folks. If you're interested, all our training is free, and it all typically has CEs, CMEs, recovery, LADAC, KDAC, the whole 9 yards. And one that I would bring, given what's happening right now, which I think we're all still shaken about, is we have Ayanna Jordan, just by coincidence, talking on Thursday, and she's done a lot of work on racial injustice and structural racism, and she's talking on COVID-19 may be terrible, but I'm more likely to die from structural racism.
Actually, I've signed up for that. You guys do a lot of good trainings. I've sat in.
So that's a webinar happening on Thursday from 1 to 2 that you have to register for, because we actually just had to reopen it at 1 over 500.
Wow.
But she's really dynamic and passionate, and we're actually got permission to tape it, so we can share it with you afterwards if you can't make it.
Great. Thank you.
So,
Yes, please share it.
Mary Ann, we have also Teresa Young from PAFS.
Yes, we do. I have her coming on in 3 more sessions, unless she needs to go on right now. We have about 3 more other people.
Oh, okay.
Yep. Very good. Excellent. Thank you so much, Colleen. Paul Bowman, are you there?
Hey, yeah, I can be really quick too. So
You can.
anyway, I'm actually working now at the South End Community Health Center, so it's kind of really cool that I'm coming to the Boston meeting of MOAR, because I'm now working in the South End, which is really cool. Yeah, so I'm working part-time over there. I've been there since December. I think you know that, Mary Ann. Anyway, and I wanted to thank Colleen, because I'm going to one of those recovery coach chat drop-in sessions, and they've been really incredibly supportive. I've been helping facilitate one of them, and it's just been incredible. But I'm not here to speak on behalf of the South End, because I kind of just decided or got invited late, so I didn't get permission to talk about what they do there, but they do incredible stuff there, and I'm really glad to be a part of that community health center. And next time maybe I can talk about that, but I just probably should ask them first. But so I'm the NAMA Recovery Massachusetts representative, which is a National Alliance for Medication Assisted Recovery. So my biggest thing has been with COVID is the OTPs, the opioid treatment programs, which are the methadone clinics, and how that's been going. And that was a really rough start, but hey, it only took a pandemic to get us to be able to get people finally the take homes and everything else. And you know what? I'm so happy that things are working out, because I've been trying to get this done for my whole life, it seems, at least for 10 years on the BSAF board and all the other things. So many people have been there with me, right? When we talked about OTPs and take homes, and we only had 6 in Massachusetts and people only got 4. And you know what? People are getting them, and the sky hasn't fallen in. I think I saw that in the Boston Globe this past week. Somebody said that I know, I can't remember who. Anyway, so that's really good news. So we're hoping that, I think, was it Matt who said it, that, hopefully that can continue. I know they do a really great job with counseling, and I can't believe that they're still doing the counseling as much as they're over there, because nobody else is doing that. That's for sure. As much of the counseling as they're doing. So that's incredible. But I am just really happy to hear that. But we did, have a rough start. Like I said, we had a demand letter to SAMHSA, and we have new regulations that were supposed to be promulgated at this point from BSAS. I think you guys know that, right? That they were going to change the reg. So that kind of slowed down because of COVID. So that's definitely something that I would want to keep, is that, and some of the rules around that stuff. But it was a real rocky start at the beginning, because people weren't given the take homes to people, and there was no, the clinic. It was just rough. I don't even have to go into it, but now things are really going smooth. I think there's only been very few diversions. I think no deaths that we're aware of. So that's just incredible news. So and the recovery coach chat thing has been really full of people, and it's been an incredible support, to people that were coaching. So I'm working at the OBAT at the South End, and it's really been a lot of, because this is a big career move for me. I was working for the state for the last 25 years, and now I'm actually a recovery coach, which I've always wanted to be. So I'm happy to be here, still fighting the fight, doing my methadone advocacy, and seeing things go well. So even though this is a really, really horrible week and weekend, that some stuff, you know, it's really been hard seeing everything on TV and living through COVID and helping people in recovery and people that don't have any place to go and live and be on the street. It's difficult, but I'm just happy to see that at least some of the people are getting stuff, making it a little bit easier for them. So I'm really hoping once we get past this pandemic that things will be better, you know, and people will be able to get a little bit better, you know, luck and less overdoses because they get some access to medication, assisted treatment. So that's about all I have.
Yeah, thank you for all your advocacy, Paul. You really bring about that people do recover on medication-assisted treatment, because for a long time people didn't believe it. You know, people like you, everybody has to.
Thank you.
Can you tell people one more time what NAMA stands for?
Yeah, so it's the National Alliance for Medication-Assisted Recovery. It used to be the National Alliance for Methadone Advocacy, right?
Mm-hmm.
So then when buprenorphine came around back in 2003, we had to include that. So we changed it to the National Alliance for Medication-Assisted Recovery. So it's NAMA Recovery.
Very good.
www.methadone.org. It's a national organization that's been around for about, I'd say 25, 30 years now. And I sit on their board of directors, and I'm the Massachusetts director for NAMA.
That's fabulous. Thank you. Thank you so much.
Thank you.
Very good. We can move on to Liddy Ultimo Profo from Bay Cove, Vice President of Addiction Services. What's happening at Bay Cove, Liddy?
Hi, Paul. Hi, everyone. You know, in the interest of time, I'll just kind of, you know, add a little bit to what was shared. I think, you know, John talked earlier about kind of the initial impact of COVID and how, you know, across all programs, you know, staff and clients, you know, kind of were, you know, had to go through kind of the initial shock of how do we manage this? What do we do? You know, and those initial, you know, days were quite rough and quite tough because, you know, you had people with pre-existing conditions that, you know, would have wanted to stay and work in programs, just could not as a result of that. And other folks just out of fear, just, you know, had a tough time really trying to balance, you know, whether or not to go to work or, you know, to stay home with their loved ones. And so for a brief period of time, we had to sort of readjust with some staffing issues and, you know, to get program going. But that settled very quickly as a result of a lot of training, coaching, support that we provided to the staff, which I think we're still continuing to. I don't know if others are experiencing this, but, you know, you still kind of get a sense of sort of the fear among staff still, you know, of this disease and, you know, and just kind of figuring out kind of what to do, you know, with the situation that we're in right now. But some of the things that we did was right away, as soon as, you know, the pandemic started, we decided to come together to look at possibility of how we can screen, you know, for COVID for, you know, the folks that were coming into the program. And we came up with some pretty quick, you know, and generic ways of kind of looking at whether folks had, you know, high temperatures and, you know, whether there were recent hospitalizations and those kinds of things. We were trying to kind of gauge to get a sense of whether or not there was any risk for exposure. Over time, we soon learned that, you know, we did have some, you know, cases where people could have been asymptomatics and none of those things would have showed. And so we then had to kind of adjust some of those, you know, screening tools and processes. But at the same time had continued to, you know, admit clients into the programs. We quickly also established monitoring rooms. You know, we had to use some of the monitoring rooms because we did have some clients that did, you know, experience signs and symptoms of, you know, COVID and were later, you know, sent to the hospital where they were tested positive for COVID. And so we, through the monitoring spaces that we established, we were able to care for those clients until such time we could get them into a hospital where they could get care. And so those were very helpful, and we continue to maintain that capacity as we continue to admit clients across the continuum. I talked about training earlier. A lot of the trainings that we did were for staff as well as for the clients, because some of the clients were also very fearful of other people coming in, not knowing whether or not they were going to be exposed. And so a lot of training around how to use masks. We're still having to sort of, talk to people about continuing to wear their masks in the program. We've made it a requirement for everyone in the program to wear masks, even before it was the requirement statewide. We felt that that was very important for everyone to do. And so as soon as, a patient would walk into the program, we were providing them with masks so that we can ensure everyone's safety. We did a lot of training around universal precautions, teaching people how to keep themselves and each other safe. And really just coaching and helping people to still be receptive to new clients coming in, because there was a lot of pushback, where folks kind of weren't sure whether or not they were going to be exposed. And so we had to say, we're still in the middle of an opioid epidemic, and we need to do everything and anything possible to help each other. So, and then I think some of the other things that we did as well in terms of social distancing, which we felt quite a bit. As you know, most of the programs don't have a lot of space to operate in to begin with.
Right.
And then now we have to socially distance. So that meant adjusting our group schedule, adjusting meals times to make sure that, people were appropriately distanced, but still maintain kind of normal programming schedule. And so what that meant was sort of, having to add on more time and more groups, more meal times to spread out, if you will. We, started to work, as John mentioned earlier in the beginning, we decided to kind of work within the continuum to transition people from one program to another. But within a few weeks, we realized that we really wanted to sort of open up again and allow for more clients to come in. And so we coordinated with a lot of programs, Gavin in particular, and others, to really start to coordinate around sort of transitioning people in between the programs. One thing that we did within our residential programs and the TSS is that, those are programs where people were accustomed to going out for appointments, to see their primary care providers and the likes. And so because of COVID, a lot of those appointments people were not able to keep. And so we coordinated with a nurse practitioner to be able to see our clients via telehealth and to provide that support. Through that, we are also able to, have people be seen, but also connect our nurse practitioner with their provider. And that helped a lot, for folks that had sort of, conditions that needed to be seen, but just would not be able to do that within an emergency setting, given, all the things that were going on with COVID. That's been successful, and we want to continue to keep that and have that NP support continue. We're also using telehealth, to support the clients within our methadone program through outpatient. So Matt talked earlier about doing the groups, meeting with people individually and doing the telephonic individual counseling. Similarly, the methadone program serves upwards of 400 clients a day. And so within a matter of days, we had to move towards the take-home, model as well, where we have several people that are now on the 14 to 28 day schedule. And similarly, we've had no issue, thank goodness. We have a few people, I think about 80 or so, who are dosing daily, as opposed to sort of the larger groups. And everyone have been well. And, I echo some of the sentiments that Paul shared, as well as Matt, around that as well. I think the only other piece that I would mention is that we've also been working really hard at connecting the clients virtually for their commitments, and also community, sort of a lot of the meetings that were happening that they used to go to, not being able to go to those meetings. So we've been able to do sort of virtual AANA and getting them connected in-house. Because I think someone mentioned this is really, highly isolating times. And so we wanted to really give clients an opportunity to sort of connect in other means. And so we've been really successful at getting people to use the TVs in the houses and connecting them to the phones and sort of linking everywhere in any way possible so that they can have access to those groups that are being provided virtually. One lesson learned for us, I think, would be to increase our internet connection power, because a lot of people are connecting through the internet, and sometimes you find that you need a lot of more gigs to you know, to get all the wireless connections going on in programs. But we're here and doing anything and everything we can to support the people that we care about.
Wow, thank you. You've covered quite the gamut of everything that Bay Cove does, and it's as you said, like from the beginning, the actual fear, the fear of the staff. How do they protect themselves, and how has it been with getting the protective gear?
Well, I think like everywhere else, it was really hard in the beginning. You know, we for the first few days, we literally had to, you know, go take every mean possible to get access to the PPE. Luckily for us, we were able to do that very quickly and, you know, and just, you know, put it out to programs as quickly as possible. You know, and we were also able to get some really nice friends of the organization, make some really nice donations that were able to kind of stretch our supply quite well. And so I think we were very fortunate and blessed to have had those opportunities. A lot of people came forward to donate masks, you know, you name it, shoe coverings, gowns. And so we were able to use that. We also used some of the state resources that were posted. We used the Boston MIC, and we were able to get some supplies through them as well. That was, you know, very, very much, you know, it went very well to really get all the programs, not only ample supply, but really we crafted what we called COVID kits, so that in the event that there was someone who was positive on the unit, staff didn't have to go and scramble. We had the kits readily available. And whoever on the program, you know, all staff were trained to know what types of PPE they needed, and they had the kits readily available to go and take. And we had ample supply for about 2 to 3 days that they could use up until such time we were able to transfer the individual to a hospital if needed. So we got creative, and I think right now a lot of the things that we put in place were protocols that you had to kind of pull together relatively quick, you know, in a quick fashion to get things moving. And so now part of what we're doing as next steps is really establishing sort of long-term, you know, strategies and systems and protocols to really weather this out, because this is going to be around for quite some time. And so that means structuring our offices differently, structuring the spaces differently. What we thought could have been temporary is going to be a long-term thing. And so we're really just shifting our whole structure to really function in a new world, which is COVID, the new normal.
Oh, thank you. Thank you so much. That was extremely, extremely helpful. And I'm so proud to know you. Thank you, Letty. And now we have Emily Stewart from Casa Esperanza.
Hi, everybody. Hi, Marianne. Thanks so much for having us tonight. It's great to have a chance to see everybody's faces and talk with everyone and hear all of the amazing things that everyone's doing. Liddy, so great to hear what you guys have going on at Bay Cove. Always learning from you guys for sure, and all the other great programs. I wanted to just respond also to something that John said earlier on the call.
Well, right now.
He asked a question about, you know, whether or not we were seeing that people who were getting their stimulus checks, their tax relief checks, whether they were taking that money and leaving. And so I will say that we did have some real concerns about that in the beginning. And I won't say that it didn't happen at all. I think there might have been 1 or 2, but largely I want to say that staff did such an amazing job, and patients have done an amazing job of really being very focused on their recovery despite all of the challenges. And that I think, like so many other folks have talked about, is that, you know, sometimes, you know, we have worries about how people are going to handle certain situations, our patients, our clients. And then people in recovery always amaze you, and they always surprise you in the way that they're resilient, in the way that they step up. And so I would say a lot of our patients got their checks, and, you know, they wondered about leaving, but I think through staff working really hard and patients working really hard on their recovery, folks decided to stay, despite the fact that, again, being in treatment right now has not been an easy thing. Being in our CSS programs, I'll say very specifically, we had people who could not go outside for more than 51 days in a CSS setting. That's supposed to be a 10 to 14-day program. That program is located in Tewksbury State Hospital. There was a lot going on in Tewksbury. And so there was a lot of very sort of strict protocols around, you know, no visitation, no people coming in and out of the unit. What I want to say about that was everybody worked together, staff and patients alike, and really followed protocols. We also, like Liddy mentioned, we went to using PPE very, very early, well before it was a requirement. We had everybody in masks, staff and patients. And I have to say, we were extremely lucky. We only had one patient who tested positive for COVID on that unit over this entire time. And that person isolated fully on our unit in one of our quarantine rooms that we set up within the first week of COVID. And that individual was completely asymptomatic the entire time. He was really well cared for. He stayed in the program the whole time, and he continued on for some time after that. So, I mean, I think it was really just a testament to everybody, again, staff and patients coming together, recognizing the challenges, finding creative solutions, and you know, staying committed to the principles of recovery. And so, yeah, I mean, I think we continue to worry about people dropping out, people being afraid now to come into care. We definitely have seen a real decrease in folks who are looking to, you know, who are concerned about coming into a congregate living environment, right? And so they're weighing that balance of saying, how much do I, you know, feel like I really want treatment and I really want support? And then also, what are my fears about being in a congregate living environment? So we're really trying to educate people, educate all of our referral sources, educate people in the community about the different sort of safety protocols we have in place to try to help people feel comfortable about coming into care. And again, it's, you know, it's a choice. The street is not a safe place for folks to be right now for a lot of reasons, but also people have fears about being in congregate living environments. So we really want to try to educate them and help them understand the ways that we're trying to keep them safe in these environments. So I'll just say quickly, a lot of the things that we've done really echo a lot of things that folks have already said. Lots of communication, lots of training, making PPE available as much as possible. We also went, you know, faced some challenges securing PPE, although right now I'd say we're really well stocked. Again, we've been able to utilize the MEMA programs at different times when we had to, but mostly we've been in a pretty good position. We're also very grateful to, you know, we're members of ABH, and ABH also helped to facilitate, you know, organizations being able to secure some PPE. So we were really grateful for that. You know, I think a lot of the things that we've tried to do to sort of change the equation around social distancing is, again, like Liddy mentioned, we had a lot of challenges with the fact that our buildings didn't have as much Wi-Fi as we needed to really support people engaging in telehealth. And so we really, we sort of blanketed our buildings with Wi-Fi now. It's one of the biggest investments that we made very early on. And I have to say, it's truly now paying off. We invested in a lot of telehealth equipment too. So what we've been able to do is make sure that even while people are spread out within the residential programs, that they can all participate in groups together. So it's our Resi folks who are in a Resi program together, but they're really spread out physically, and they can still participate. And that is also allowing them to then participate in other telehealth services. So again, they're medical providers, they might have an outpatient therapist or other providers that they're communicating with. They can do that through telehealth. We were able to support a lot of our moms in our women and children's program are in the reunification process. So early on, I think one of the hardest things was moms who were in the reunification process who could not see their children, and that visitation was temporarily disconnected. Luckily, we have been able to work really closely with DCF and be able to reinstate that process. And so now moms are able to do in-person visits when they're in the reunification process. We have a lot of screening protocols in place. But initially it was really all via telehealth that, but we were really grateful that we were able to put those resources in place so moms could still stay connected to their children. And now we're trying to make sure that dads in our Resi program can also do visits with their children, with their family. People stay connected to their families, their friends and allies through telehealth as well. So we don't, or telecommunication services, right? It's not telehealth, but really making sure that people are able to still have that face-to-face communication with their family, see them, via our telehealth platform. So we're really trying to make that happen. I think some of the other things, really trying to prioritize making sure, again, that coaching and support is there for staff. So in addition to training, I think we did a lot around, we've had ongoing sort of process support groups for staff since, really early on. I think this was something we were working on putting in place before as part of our sort of trauma-informed approach to care. I think one of the things that we saw was that we needed to speed up that process when COVID hit. Now we see the real need that staff have. It's, I think one of the challenges that we've really faced most is, our staff are also experiencing a lot of the underlying health challenges that would also put them at risk for a serious course of COVID should they become ill. And so we really wanted to make sure that we saw how stressful it was for staff to make the kinds of choices that they had to make about coming to work. And so really trying to make sure that people had that support on an ongoing basis, recognizing again that COVID's not going away, and recognizing specifically the disproportionate impact of COVID on communities of color. And, our organization is, we're a Latino organization. Our focus is serving the Latino community and communities of color. And our staff are people of color and, and are people who are living also with those disparities and that disproportionate impact. And so really making those choices and thinking through how they were taking care of themselves and how they are also taking care of their patients. These are big choices. And so we really felt that it was important for us to take seriously how we were supporting them in thinking those things through. We really tried to support staff who needed to work from home because they had health issues to be able to continue to work with a residential population, but using telehealth to do so. So we've been able to have counselors, treatment coordinators, case managers who work in our Resi programs who could stay home. Also, folks who had childcare responsibilities were able to stay home and provide some of those services and supports through telehealth. So that was another thing that we tried to, I think, do And we've seen some success, some significant success with that. I think it's something we have to keep working on and keep thinking about. I think the other thing that we're trying to do, which I really am interested to connect with Jen and John about this, is we have just decided that we're going to start thinking about how to build outside spaces for our outpatient folks to continue to get access to care. And again, some of that is around having, again, charging stations, as Jen mentioned, but also setting up tent spaces where people will be able to have some privacy, have some headphones, and then be able to engage in telehealth services using our Wi-Fi. So because we don't have, and then also thinking about how we can modify our outpatient building so that we can continue to, once the weather gets colder, then create spaces inside our building where people could, again, utilize the Wi-Fi there and utilize the space there in a totally different way so that they can then connect to telehealth services. So in other words, maybe having fewer staff on site in an outpatient setting, having them off site, but having patients on site so that patients can access telehealth, but having them spread out. So really just totally rethinking the way that we're using our space to plan for that long haul, as Liddy said, because we had a long way to go with this. And so we're trying to think about, again, how do we take advantage of the good weather now that we have and be creative to get people access to. We've raised money to try to get tablets and phones for people. So we're distributing personal electronic devices for people, but then also figuring out how do we get people access to Wi-Fi so that they can connect, so that they can use the service, right? Because if they can't connect, they can't use the service, no matter, you know, how much availability we might have. So yeah, those are some of the things we've been doing and thinking about and trying to be just creative, but the staff has just been, you know, amazing, creative, patients, amazing, patient, and engaged, and just people just keep coming at it and trying every day and one day at a time, you know, so that's how we're doing it.
Thank you, Emily, for sharing all those Casa Esperanza amazing connections all the way through. I see the flow chart in a very, very big way. And
Thanks, Marianne.
You're very, very welcome. And one agency that does a lot of connecting to everything is PATHS. So Teresa Young, hello. Would you share a little bit? What does PATHS stand for?
PATHS is providing access to addiction treatment, hope, and support. And in a nutshell, it is the City of Boston's resource and referral center for all things addiction treatment. So that means we take people on a walk-in basis, wherever they're at, and then have a discussion with them about what they're looking for that day, do an assessment, and then start the referral process for whatever is a good fit and whatever they're looking for. And along with that, we're trying to decrease or minimize or eliminate, hopefully, the barriers that people experience while they're trying to get into treatment, especially the folks that we serve, which is it's primarily in the Mass Ave, Melnia-Cass area, though we do get people from all across the state. That we didn't close our in-person operation just because we're really not able with the services that we provide and the people that we see. Like so many people mentioned, access to phones and computers is really tough for folks that are chronically homeless. So we had to provide a space that they could utilize them. So we didn't really have many options around telehealth. What we did try to do was add the capacity to help people access their providers via telehealth. So if someone came in, an example is like we had a gentleman come in, he had a psychiatrist at MGH, needed to do a telehealth appointment, otherwise wouldn't have been able to. So we made that possible, and for anyone that needed it would have made that possible, just so that the folks that we're seeing get disproportionately impacted by this because of the lack of access to technology. In terms of like protecting folks and trying to minimize the spread, we did have to limit the number of people that could be in our waiting room, which we previously ran as a drop-in. So I was sad that we couldn't continue to do that, but it was definitely out of the interest of people's health. So we do a screener for everyone that comes in every time that they come in at the front door. So that's temperature and then, the CDC questionnaire. And then based on that, we kind of figure out what the next steps are. So if they had a test and they don't have the results, we're going to help them track down the results so that they can show that to treatment providers so that doesn't become a barrier. If they haven't been tested and were symptomatic, we worked really closely with Healthcare for the Homeless to get people tested and to try to follow them and say, like, come back, and as soon as you come back with the results, assuming they're negative and they're not transferred to some of the other locations where folks are being taken care of, then we'll get you into care. And then even if they had negative test results, we're just trying to help them get documentation so it didn't become an issue when they're trying to get into treatment. I would say and we also provided masks to folks in hand washing stations in front of the building and in the building to just try to help people practice good hygiene and keep each other safe. I would say we didn't see much of a slowdown in terms of our ATS placements, which was really a blessing because people really needed it. We did, as I think John and Liddy both mentioned, initially folks were trying to understandably admit and monitor people within their own system. So we did see a slowdown a little bit at the beginning for off-the-street admissions to further treatment, longer-term levels of care. But I would say in the past few weeks that's been improving. So that's no longer something that we're running into, which is a good thing because for a while there, it's totally understandable that people wanted to monitor folks in their setting and take care of them in their setting. It did have an impact on people that were trying to get into treatment from the street. Let's see, what else? I think that covers it. I think, we've had a great team. We've been really fortunate to have them really rally around all the changes because we made a lot of them. And I think we didn't have to limit our hours too much. We stayed open 7 days a week, which I'm grateful that we had the staff to do. And we're kind of just, like everyone else, hitting the stride with the new normal because I don't think we're going to change a lot of protocols and social distancing protocols very soon. This is going to be around for a long time, but we're adjusting to it, which is a good thing. And I think also the folks that we serve are getting used to it, whereas at first, they already have so much stigma, and then having to come and do like a screening and have another barrier to getting care was hard for people in the beginning, kind of like, why are you asking me all those questions, with the anticipation that maybe this is just another reason to turn them away instead of looking at it as like, no, this is a way for us to keep everyone in the community safe. So that's about it. We just had to be flexible as different programs are reporting back to us kind of what their requirements for admission are, just trying to adjust and accommodate as much as we can so we can get people where they want to go. But I've been grateful that we've been able to stay open and do what we do every day.
Wow. Teresa, do you work with recovery coaches or outreach workers that refer to paths?
Yep. So we have a whole outreach team for the Mass Ave Melnia Cass area. So they've been super helpful in when someone doesn't know where to go or doesn't know where paths is, kind of like doing the warm handoff. And since there's been a lot of I think challenges with different services providers. So for an example, like people from Pine Street Inn reached out to us about housing. And of course you don't want to have COVID be a reason for someone to not continue forward with their housing process. So they might reach out to us and then we'd reach out to outreach, be like, can you find this person? Have them come back and let's facilitate even their housing, which is not something that we would do previously, but just because we just want to minimize the impact of this.
Wow, amazing. And what's the demographics in as far? Do you have many people of color coming, age, what have you?
Sure. So we do have a large population of people of color, just because our location in a major city, and we try to hire and staff reflect that so that people are able to, even reduce stigma even more. Age, I would say we mostly see folks in their 30s to 40s. So we do see like the whole range. We see some people that are very young and some folks that are in their 60s and 70s, but the major concentrations like 30s and 40s. And we see 70% men, 30% women, which I think we could do a little better on that for our females, but that's kind of the breakdown that's been for the past few years.
You need to know, I meet people across the state and everybody speaks so positively about PASS. You have a way of sticking with people and supporting them until they get the help and support they need, which is wonderful.
I appreciate hearing that. That is definitely like one of our core values is there's never too many times to try. So we want to with people in that way.
Very positive. Wow. I'd like to ask Connie Peters, what is MCAS doing and what does MCAS stand for?
Oh, all right. I knew you were going to drag me into this. It's the Massachusetts Coalition for Addiction Services, and Marianne and I have been working together in this coalition for many, many, many years now. I don't know. I keep losing count. 18, 19, I don't know. But anyway, yeah, the coalition, because of the COVID-19 pandemic, we had already come out with our set of recommendations and had been doing a lot of legislative meetings until COVID-19 came along and then like kind of came to a stop. So just recently we reviewed our budget request, as was mentioned earlier on this meeting, that we are looking at significant budget cuts if the federal government does not come through with money to bail out the states because of COVID-19. If you look at I think someone mentioned the $5 to $7 billion. You know, the state runs like a $45 billion budget every year, and I think I heard it was like a 15% cut, which I think is about $5 billion. But anyway, that's a big cut, and there isn't a lot of accounts for that money to be taken out of. And unfortunately, Health and Human Services, which provides all these social services through all the different state agencies, you know, is one of those places they could pull money. So anyway, MCAS has revised its request. We're certainly asking for level funding in all of the BSAS accounts, main line item. We are asking, one of my biggest concerns is, I'm sure some of you have heard of Access to Recovery, which is a very popular and supportive program. It's one I really like, but it's mostly funded by the federal government and partially funded by the state. I'm hoping they still get their federal funding this year, but we are asking the governor, and when he put out his budget proposal prior to COVID-19, he had only left like 1.5 million in there for ATR, and we need at least 3 million just to sustain what they're doing now. And so that is one of our top budget priorities. Another one is to keep, we got 2 million for BSAS. These are all things that are already in place and just need to be annualized. We got rid of any request for new money. But BSAS this past year, we were able to get them some technical assistance funding to provide TA to providers in the field and their staff, primarily around medication-assisted treatment and serving people with co-occurring mental health and substance use disorders. And there is some work being done on that. We want to see that funding continued. These are critical issues in the field, and you know, I just want to make sure that our staff are up to speed on all the best practices in serving those populations. And then our third request is, we started an initiative last year working with the Rehab Commission. And as you all know, we've had terrible staffing problems in the field prior to COVID-19, and behavioral health in general, both mental health and addiction. We have horrible staffing problems and a lot of staff vacancies in programs. A lot of it, I think, is related to the rates and the salaries that providers can pay. But we also just need to have more people coming into the field. So this initiative with the Mass Rehab Commission that we started last year, we want to see that continue to try and get it better up and running. But historically, Mass Rehab hasn't really focused on people with substance use disorders and recovery. And we're trying to change that and get a new model out there. And the real goal is to have people in recovery to get the education or training they need to be able to the addiction treatment, to become providers, basic services. And we're trying to have funding available to get the college degrees or master degrees that some people need, if you want to be an LADC 1 or 2, but even recovery coaching, whatever. We're just trying to put together a program there that will help build a resource or a pipeline of people actually who are in recovery who want to work in the addiction treatment provider system. So those are the 3 priorities that were funded last year that we're looking to fund again this year, but we're not asking for new money. And so those are our priorities. We have sent letters to all the members of the Ways and Means Committee, the joint committees, and when we need to call people into action with all this rioting going on in the pandemic, and we're already dealing with an opioid epidemic, and now we have all this stuff piled onto us. So I just also want to give kudos to the methadone treatment providers around this 14 and 21 day or 28-day take home. That was a big scramble right up front because nobody was prepared to do that or had the capacity to do that. But we got it. I totally agree, Paul. That's something we're going to continue to push for. It's going to be SAMHSA who makes that decision. It's SAMHSA you need to talk to. So anyway.
Well, they already have it in the federal regs, Connie. We just have to get the 8 points fixed. We have to get the 8 points fixed from SAMHSA, but we have 28 days in the regs right now, so.
Great. Oh, great. Oh, yeah. You're right. Okay. All right. So anyway, when we need help with the legislature, I think I'm hoping the federal government still comes through. It's, the House has already passed some legislation called the HEROES Act, and the Senate is supposed to take it up, but they're going to delay it now. But that has funding for all sorts of things, but it also includes, we're talking trillions of dollars here, but it has money to bail out the states, and we need the federal government to bail out Massachusetts. I can't imagine what New York is going to need, but hopefully we can make that happen, and we'll see. But what that happens there will determine basically how much of this cut we might have to absorb. And that, I have to tell you, when I started my job, we had just endured significant budget cuts through 9 months back then, and we lost detoxes and some residential programs and outpatient services, and we've been fighting ever since to get to where we are now. And now I'm terrified it's all going to go away again, Mary Ann. We have to really make this work.
We will do that. Call to action.
Yes. So we'll be in touch just if and when the time is needed.
Right. Thank you, Connie. Thank you.
Mary Ann, I just want to make sure nobody has any questions.
Oh, we do. Wendia has a question, as well as Lorraine.
Okay.
Wendia.
Okay.
Yes.
Well, so I guess this is a question. Well, first I want to say what partners, the Bridge Clinic at Brigham and Women's is still open for telehealth visits. They are reopening July 1st, a soft opening, maybe 1 day a week. It's not finalized yet, but the Bridge Clinic at Brigham and Women's is still open. It's still low threshold. People don't need to come in person for in-person, to get medication. So it's still low threshold if they wanted to get buprenorphine. So I just wanted to say that. And just a question about I heard a few people talk about the disparities and
Yes.
inequities, and I was just wondering exactly what are some of the plans that people have, during this time. COVID negatively impacted communities of color, especially here in Boston, the neighborhoods of Dorchester, Roxbury, Mattapan, Hyde Park. And so what are, health disparities are already, and poor health outcomes are already like that for these communities. And, Chelsea also was affected, and Lawrence. So I was just wondering, what are people doing to ensure that there's equitable distribution of funds? When some of these grants come in, what are people doing to make sure that things are actually equitable? And, down the line when mental health comes up, because it's going to ramp up in substance use, what are the plans for some people around equity?
Yeah. Thank you for that question, Wendy. Would somebody like to share?
Well, I mean, I could just say for us that, I mean, every grant that we have, Windia, is aimed at, and our grants all come from Casa Esperanza. Most of our grant funding comes from SAMHSA, although not exclusively. We got a rapid response grant from the RISE Foundation, and that funding was specifically for figuring out how to put services that ensured that the Latino community that we serve could continue to engage in care. But all of our federal grants from SAMHSA, all of those dollars are really being directed on an ongoing basis before COVID hit towards issues of trying to eliminate health disparities, and that's what we're aimed at all the time. I think COVID has presented a whole bunch of new challenges that, folks were already facing. Some of the things that we've been trying to do, I think, are partnering with with folks in corrections around reentry, because we do a lot of reentry work, and trying to think about people who are actually incarcerated and who can't get released because of COVID, because a lot of the county corrections have just held everybody in. So they tried to do release, and they tried to release people early, and then there were a lot of complications, and then a lot of people got stuck, and now they're stuck. So one of the things that we're helping to do is use our grant funds to help facilitate the reentry phone calls that used to happen, but because county corrections didn't have Zoom access, CASA came in and said, we have grant funds, we want to help try to create an opportunity so that we can continue this dialogue about people reentering community, and figure out, a lot of folks weren't able to get any programming or any services or supports in corrections because they changed their staffing pattern so drastically. So we've been trying to work with the reentry folks to figure out how to help create telehealth opportunities for people who are still inmates, and then create bridges for them to come back into, so as they are able to leave corrections, to come into community, into safe spaces where they can get the health care that they need, the mental health support that they need, the substance use treatment that they need. So really trying to focus on how is that going to work. I know there have been recently some funds coming from the state to provide tablets to inmates so that they are able to engage in telehealth services. And we're trying to, again, make sure that there are services on our side available to people, available to Spanish speakers specifically, but really making sure that there's that bridge for people, and trying to encourage in every way possible how to bring people back in the community as quickly as we can, so that they can get the health care and the mental health services they need, rather than being incarcerated. So that's just one of the things. I think really trying to advocate that making sure that when we're working on COVID issues, that we're collecting data, demographic data, and reporting about the impact of race and ethnicity, which was not happening in the beginning, is happening now, and trying to think more about, okay, how do we target resources and services in those communities that are most affected, like Chelsea, Brockton, Lawrence, and saying, how are we going to get, again, services to people who are trying to isolate and, you know, so that they don't have to come out into unsafe spaces to get the care that they need, but they don't have the technology. So trying to figure out, again, how to get resources to those communities and get technology to those communities. So those are, again, just some of the things. I think there's a lot of other things that we're trying to work on, but those are two key things that we've been working on so far.
Oh, thank you so much, Emily. Wendia, was that helpful?
Yeah, that was helpful and reassuring. I think, you know, it's still, you know, a lot of my work and focus is always, it's you know, the disparities and inequities for people of color. So, and, you know, a lot of diverse communities. And I just want to ensure during this time, you know, I'm having a hard time with everything that's going on. And I just want to ensure it's, you know, it's hard to see, you know, these things happening and to know people that are involved with this personally. So it's just something that's kind of my passion. And I just want to make sure that organizations are doing their part and standing with, you know, not, it's okay to be, not okay, but, you know, people are not inherently racist, but we also sometimes need to be like anti-racist and stand on that and say we are not going to, you know, step into these racist systems or give into these racist systems, and always have to think about who's not in the room and why aren't they in the room.
Right. Totally agree with you, Wendy. I just wanted to be able to say, I know MOAR is going through a consult right now with the whole thing about disparity, equity, and inclusion. So we can do a better job at this. And I would love to meet with you and other people who want to be able to work on this, because as for many, this last weekend, it broke my heart, and I'm far from the only one, but watching those thousands of people walk the streets. And so I applaud you, and I applaud your advocacy, and it needs to be listened to. So thank you.
Did you have another question, Wendia? Oh,
she's gone.
No, I didn't have another question. I lowered my hand.
Oh, okay. All right. Who else had a question? Someone else? Oh,
Lorraine.
Lorraine. Oh, okay.
Hi. Okay. So many. Are there any plans to work with the MAT clients? Do we know, with focus on unaddressed mental health or mental illness as the rollout is being planned? And also with that, as the rollout to bring people back into like methadone treatment, as that becomes more apparent and more worked upon, is there a consideration for those who are, you know, there's a lot of people over 50 on the clinics, and there's a lot of people who have health issues. Will there be a consideration? Is it going to be a number? Okay, we need to get this many back this week and this many back that week. Will there be a consideration for those who have pre-existing conditions and could be compromised, you know, in the coming back to the clinic? Like for instance, I have a client that is concerned about going, they're going to stop the not conferences, but the meetings. They meet on Zoom, but they're going to bring them back into the rooms. And he has a concern about that because he doesn't want to be in the meeting with his diabetes and his emphysema. So is that clear? I hope that was clear what I said.
Yes, actually, Lorraine, there's a lot going on both at the state and federal level around this issue because a lot of providers have found that a lot of our patients do very well with telehealth and telecounseling and all the rest and all these take-home doses, et cetera. But telehealth in particular, you know, telehealth really picked up in a lot of frontier states where there's wide open spaces and very few people. And I think in Western Mass, some of our providers picked it up sooner. But now with COVID-19, it's like everybody has got it now. And I think because we had some federal and state waivers to do telephone counseling, because a lot of our patients don't have, you know, this capacity to do video conferencing. The feds did allow telephone counseling for the OTPs to do. But a big issue, like has already been mentioned, is getting telephones to all those patients. But we are definitely mounting efforts at both the state and federal level to push to retain as much activity through telehealth as possible. A lot of our patients are very comfortable with it, like it. Why go stand in line at a methadone clinic if you don't have to, you know, or traipse around? I just don't know how much of it we can retain. I'm pretty sure the straight telephone counseling will go away eventually after the COVID pandemic is over. But we're going to hang on to as much of the telehealth as we possibly can.
That's encouraging. That's very encouraging.
We're definitely.
Connie, are you worried about any of the CMS stuff that, you know, that we have for like recovery coaching that's kind of extra that's in Medicaid and Medicare? Is that anything to do with you guys? That's not, you know, PSAS block grant funded, but actually Medicaid?
Oh, well, that's a whole issue I'm not even going to tackle. Yes. You mean around the Trump administration wanting to
No, just even around the state, because, you know, if we don't, the state, you know, if we get the federal program, the state has to pay 50% of it, all the extra stuff that we have, you know, from Medicaid that, you know, most states don't have.
Right. Well, so that's through our 1115 waiver. And my understanding is, I just heard this the other day, and I'm taking these people at their word. I don't know the truth behind it, but New York had to refile their 1115 waiver. Ours is up in another 2 years. What we're doing is hoping that we have an election and we have a new president who's be more friendly for supporting our 1115 waiver. I heard yesterday that last week, that New York had refiled their 1115 waiver and the CMS denied it. And so I'm glad we have more time before we have to refile, because hopefully we'll have a new administration to work with. So I honestly, there's no predicting the future on all of this. None whatsoever. And also, I just want you to know, ABH has been working, especially, we have a committee up and running around underserved populations. Emily Stewart, are you still chair or co-chair of that, Emily?
I am. Yep.
Co-chair.
Absolutely. And I don't know who the I am currently the chair, but I'm not sure if we have a new co-chair. Henry Easter was the founding co-chair.
Right.
But yeah, the committee does exist and is working.
Yeah, so I mean, I'm getting old. I've been around a long time. I've been through many riots in my life. Not me personally, but I've witnessed riots around this country for many, many times. And many times it's often due to racism. And, you know, I think most people fully support this effort. I mean, they've all been out there rallying, and they're very peaceful protesters. It's definitely, I'm just hoping this time we can have an impact, but I'm not sure it's going to happen under this administration. That's all.
Just to add what Connie said about the partnering with Underserved Populations Committee, unfortunately, I had taken a short leave of absence, so I'm still getting caught back up with what's happening with the committee since I've come back. But I did want to just mention that, you know, the Partnering with Underserved Populations Committee at ABH, part of what we do is really sort of advocate around issues of how can we work together as a behavioral health community to address and eliminate disparities for underserved communities. And so that's a range of different groups, but particularly communities of color are a big area of focus, and thinking about how do we address health disparities, how do we bring light to the policy changes that need to get made, as well as the funding changes that need to get made. So I think, you know, working with state partners, working together as providers to identify those places where disparities exist, and then being able to make sure that we're trying to advocate for sort of what are the resources, what are the, again, the relationships with our partners, to try to figure out how to, you know, dismantle the structural racism that exists, and to make sure that people have access to treatment and services and supports, rather than, you know, people finding themselves, you know, addressed by law enforcement and incarceration. So we want to make sure that people get access to care, and that people get, you know, and that we're able to address issues of equity and health disparity. So that's really what the committee is about, and that's, you know, the goal of that group. So, and we're very grateful to ABH, to the entire ABH leadership for, you know, making that committee possible and creating a space for that type of advocacy. And Marianne, I look forward to talking to you and Windia and other folks about how we can continue to work together on these issues as a group. So
Thank you.
I think there's a lot. Yeah, I'm really excited that you guys are doing that. I think it's great. And yeah, we got to all work together on it. Absolutely.
And if I could add one piece to this as well, is, you know, Emily and I sit on that committee as well. And again, just want to echo Connie for bringing that up, and ABH really for continuing to support the group. And I think most recently, a couple of things that we were looking at also was the issue of availability of providers who are people of color. Language access, you know, not being able to have someone that speaks your language as you're going in for treatment, and sort of looking at state capacity of people who are licensed and credentialed who are people of color who can provide support to communities. And so those were sort of some part of the most recent discussions that the group was having, is really looking at, do we even have data, and how can we, you know, establish a way to collect data, you know, from the licensing boards, so that we can identify what's happening when people are applying for their license, what kinds of hurdles are they going through. You know, Emily mentions, you know, the piece around sort of structural, you know, systems that really kind of hinders progress to happen. And these are the kinds of things that we were looking at as well as a group, to figure out how do we, you know, cut through some of these, you know, issues, these barriers, to make sure that we're able to support people. The only other thing that I would add is that conversations need to happen, you know, in places across, you know, our programs as well. If we're not offering people the opportunity to talk about what's going on, you know, we should. And I think, you know, it's just when people have the space and the time to really address and to talk about, you know, what it is that's going on out there, this is where the healing begins. This is where we start to acknowledge and also accept the fact that, you know, maybe structurally we too might need to do some things to, you know, within our own structures, within our own organizations, you know, from the people that, you know, we bring into programs to, you know, to help, to the people who we hire, to the structures and the systems that we also have. And so I think, you know, as Connie said, we hope this is the time that change happens, but it comes from us doing what we need to do as well to make sure that it does. So just add to that.
I saw a question there. What is ABH? ABH is the Association for Behavioral Health Care. We are a trade association that we represent the providers of mental health and addiction treatment services across the state. on policy, programmatic, and budgetary matters, regulatory, et cetera. And a lot of the providers, we have 80 provider members. They pay dues to our organization, and everyone in the office is pretty much a registered lobbyist. So we can go to the State House and to the administration and advocate on the behalf of the provider system primarily for the people they serve. So
Never knew about it.
anyway, that's advice services.
Excellent. Thank you so much. Well, we have covered the gamut of things, the experience and for next steps. And we're hearing a lot about telehealth and helping people that need the equipment to get that. And also how we need to keep that connection going. And we want to be able to rule out disparities and do better outreach to where disparities exist and continue to connect to communities of color and wherever there may be a need. And you heard Connie talk about our Mass Coalition for Addiction Services move on the budget, and your voices will be needed. And I thank you all in a tremendous.
Wait, Mary Ann, I heard also we want to continue the conversation. We want to keep the conversation
Yes,
going.
yes,
Okay?
yes. Yeah, it doesn't end here. No. That's why numbers are going on that sheet. Yes, yes, yes.
Mary,
yeah. What?
I'm
What
sorry,
did I
it looks like you have a halo over your head.
Oh, a halo?
It looks
yes.
over your head.
Don't let her fool you. She's a little devil.
Oh, I was going to say, you're an angel, Mary Ann.
What?
So thanks everyone for coming. Please join us next month.
July 6th, if that works. Yes.
Yeah.
Thanks,
Exactly.
everybody. Recovery's
And
real.
yeah.
Thank you, everybody.
Day is September 23rd. It may look very different because of COVID-19, but we'll talk about it. Thank you.
September 23rd?
Yes.
Okay.
Recovery's real. I said it.
Thank you. Wow. Very good.